Bismillah ar-Rahman ar-Rahim. This is Professor Abdussalam Yasin Taha from the College of Medicine, University of Sulaimani, giving a short speech entitled Severe Dysphagia due to food bolus impaction in a young man. Case. A young male patient was admitted to Sulaimaniya Teaching Hospital, Sulaimaniya, Iraq, because of severe dysphagia following ingestion of a meat bolus. He was subjected to urgent rigid esophagoscopy under anesthesia, during which the meat bolus was removed completely and the patient had a smooth recovery thereafter. It was the picture of the patient under anesthesia through an endotracheal tube. The piece of meat removed using the rigid esophagoscope. Food bolus impactions are commonly accompanied by some underlying component of pathology, which can be either mechanical or functional. In terms of mechanical etiologies, strictures or narrowing of the esophagus are most commonly caused by Schatzki ring, peptic stricture, or increasingly the presence of eosinophilic esophagitis. In terms of motility disorders, diffuse motor abnormalities of the esophagus or esophageal spasm can cause transient food bolus impactions. In these patients, the impaction generally passes after a period of relaxation where the muscles of the esophagus are no longer constricted and allow the bolus to pass. Not surprisingly, impactions occur more often when patients are eating meat and generally when they do not chew their food sufficiently. Contributing conditions could be poor dentation, ill-fitting dentures, the use of alcohol, or a predisposition to eat too quickly. The most commonly impacted foods are beef, chicken, pork, and al dente cooked vegetables. Anything put into the mouth should ultimately be considered a foreign object, including the contents of a food bolus. Thus, one of the appropriate concerns in the evaluation and management of food bolus impaction, particularly in a meat impaction, is whether or not there may be unrecognized bones in the food bolus. Again, radiographic imaging can be helpful in this regard. Quality plain and lateral film of the chest and neck should be taken, depending on the location of the suspected impaction, and examined carefully for evidence of bones. This may also be scrutinized in the patient history. Patients with a food bolus impaction that persists to the extent that they present in the emergency department should receive a chest radiograph to rule out evidence of perforation or a radio-opaque object in the esophagus. Once a foreign body is ruled out, endoscopy should be considered. Several factors should be considered regarding the timing of the endoscopy. The status of the patient's airway and ventilation needs to be evaluated to ensure adequate control and assess the risk of aspiration. Patients experiencing excessive sialuria who are unable to handle their secretions have an indication for urgent or emergent endoscopy. Further, it is known that food bolus impactions that persist more than 12 to 24 hours confer more risk for serious complications, including esophageal perforations. This is the bibliography used in the preparation of this speech. بسم الله الرحمن الرحيم. ربنا لا تؤاخذنا إن نسينا أو أخطأنا. Our Lord, do not hold us accountable if we forget or err. Al-Baqarah 286. With this verse from the Holy Quran, I would like to conclude my short speech. This is Professor Abdulsalam Yassin Taha signing off from the College of Medicine, University of Sulaimani.